All right, good morning, friends. We have a case study today. Why not a slow code? And this is in our course right as we switch from truth telling in the medical healthcare setting to third-party obligations. So the last couple classes, we spent a lot of time on what the proper relationship is between a patient and a healthcare worker or a physician, uh, and largely recently in the context of truth telling, right, versus what we call therapeutic privilege or stage disclosure or any of these forms of medical paternalism, right? And always in an effort to do no harm, right? The idea is that truth telling harms somebody, therefore you're justified in lying if it's going to harm somebody. So, why not a slow code? I'm going to try to read through it pretty quick, summarize the big points, and we'll rock and roll. So, Dr. Holbert, a senior neonatologist, was called to attend a patient he knew very well, Mrs. Gage, during the birth of her first child. She was at the hospital with her husband and was about to deliver the child, who had been prenatally diagnosed with a number of severe deformities, including a congenital diaphragmatic hernia and severe cardiac anomalies. Dr. Holbert had had a number of frank conversations with Mrs. Gage and her husband and informed them that their child's anomalies were very severe and possibly life-threatening. Despite this, she and her husband uniformly insisted that a full and aggressive resuscitation be undertaken. At the end of their most recent discussion, Mrs. Gage agreed to let the team make their initial assessment at the time of delivery and discuss with her and her husband how to proceed at that time. Dr. Holbert felt this was a reasonable plan. With his resuscitation in place, Dr. Holbert received a newborn baby boy who had a weak pulse and was making labored respiratory efforts. Upon reaching the infant warmer to assess the child, Dr. Holbert realized that the anomalies were more severe than initially expected, and though they might be able to keep him alive temporarily on maximal support, he would most likely never leave the ICU. When Dr. Holbert repeated to Mr. and Mrs. Gage on their son's condition and his prognosis, what he thought the outcome was, they said, "We want you to do everything. Please don't let our son die." Trying to balance the good of the child and the emotional needs of the parents, Dr. Holbert turned to his team and quietly instructed them to undertake a slow code. So, what's going on here? Well, on the one hand, he wants to respect the wishes of the parents, right? Who want to do everything they can for their child, regardless of anything. They don't know, they don't have the medical expertise he does. But, excuse me. On the other hand, if Dr. Holbert respects their wishes and he does full and aggressive measures on this baby who he knows isn't going to survive, he's going to cause that baby a lot of pain and suffering in its first day or two, right? Baby doesn't need to know much to be able to feel pain, yeah. And if you do a full code, you're cracking ribs, you're intubating, you might even be using electric shock, not pleasant things. And so we're doing ethics, folks. We have to resolve conflicting values. So, many medical students, residents, and other medical staff learn the elements of a slow code early in their clinical years. It seems to be part of the wisdom that some experienced physicians pass on. Following a long history known among the medical profession, but not generally known to the public. Concerning much? The intentions behind a call for a slow code are good. Primarily, it is a way to spare parents the full, painful acknowledgement of the extent of their child's deficits and the likelihood of his extremely poor quality of life or death. More importantly, it shields parents from having to make the painful decision to let their child die by choosing not to resuscitate or to stop treatment. It also protects the infant from the rigors of aggressive treatment that is likely to be unsuccessful. It must be acknowledged that calling a slow code also spares the physician the helpless feeling of doing nothing, having to face parents with empty hands. He or she may also have a lurking fear of parents' anger at the physician's failure or malpractice charges if the infant dies with no medical interventions. However good the intentions, though, calling a slow code raises significant ethical questions about deceit, paternalism, patient-doctor relationships, and teaching good communication skills. Oh, does it now? Does it raise them? Good. I'm glad someone noticed that. So, what is a slow code? A full code, or code blue, involves calling a rapid response team and initiating appropriate treatment as quickly and effectively as possible with the goal of reversing an adverse event, returning patients to the status they had before the event that triggered the full code, and restoring as high a level of functioning as possible. It is important intervention with high priority. It's an emergency intervention with high priority, and speed is often critically important. A full code, properly executed, is often life-saving. A slow code, by contrast, involves initiating some resuscitative measures but carrying them out slowly or omitting the most aggressive. Interventions in a slow code are limited in duration, number, intensity, or all three. For example, giving gentle chest compressions that do not crack the ribs. Slow also refers to the reduced alacrity with which staff respond to the call. The implicit hope is that the patient will die of his condition before they arrive. I would love for people to pause and just reflect on what their initial instincts were as we hear about what a slow code is. Do you think it has a place in a hospital, or are you horrified by it, or right? Where's your initial instincts falling on this issue? In a recent article, la da da, both experienced, respected neonatologists who are well published in medical ethics. That should raise a proposed use of a slow code as a legitimate response to situations like Dr. Holbert's. They define a slow code as a short-term trial of some intervention and emphasize that it is mainly a symbolic gesture, not expected to be effective, but to give the appearance of doing something effective. And so they're saying, if you're inclined to say this is just some dark paternalism, you're just lying to patients or parents that has no place, right? If those parents knew that those physicians and nurses were lying and pretending to rush in and save their child, but actually not rushing in to save their child, oh, how would you feel? How would you feel if you just had a new, talk to me? Or don't, but think about it. So, what ethical issues are at play with a slow code? Obviously, it's deceit because the physician is appearing one way while acting another way. Glaucon much? Paternalism. I don't want to read all the way through this. You guys will have access to it, right? But obviously, you're appealing to know what's best for the patient and their children, apart from their own wishes. Patient-physician relationship, insofar as good relationships with patients and parents or patients are built on trust, the use of a slow code by eroding trust damages or destroys the relationship. True, parents may never come to realize that the treatment order was actually a slow code, but it's always possible they will figure it out. Even if they later recognize that ceasing treatment was a better choice for their baby, they're bound to resent that they were not told the truth. And so here's how they actually feel like we should run it. The idea is that, to play the other angle, reason physicians call a slow code is because parents are typically presented with a choice of two extremes: do everything or do nothing, i.e., do not resuscitate. The problem is that the physician do everything means carrying out measures that are futile, interventions that are not expected to be of benefit and are likely to cause harm. Engaging in futile, possibly harmful measures is and should be morally unacceptable for them. For the parents, choosing do not resuscitate means giving up hope and choosing to let their baby die, which may be psychologically or morally unacceptable to them. Hopefully that's pretty clear. So here's what we do. Viewing a slow code as a time-limited trial of some intervention or the use of some non-aggressive measures allows us to see it as a compromise or middle ground between the two extremes. The advantage of proceeding is that there's transparency and no need for deceiving. The decision is made by the parents and fulfills both the ethical requirement for informed consent and the physician and parents' need to do something rather than nothing. The physician must explain to the parents why doing everything is not a good option. It's painful for the baby, will not save him or her, and will leave everyone with regrets. Limited, less aggressive measures are appropriate if the physician thinks there's at least some chance of their working based on scientific evidence and a benefit burden calculation, not just paternalistic judgment. If the physician explains his or her reasoning and actively recommends this third option and it is agreed to by the parents, then it constitutes a paradigm of shared decision making. So we see that it seems like you can just paint it in a different stripe. As long as you're not deceiving the parent, you treat them as an end in themselves and never as a means to your end. Remember this? So drop the term slow code with all the negative connotations and call it a limited trial run or limited resuscitation. So I want you to pretend like you have an eager class of peers to discuss this case study with, and think about what are the issues here. Do you know of any other slow codes that have happened? I urge you to go look up, say, slow code ethics and see how it's viewed in the workplace. Wikipedia's got a little bit of stuff on it, why it's done, the background of it, the situations in which it might appear, so not just in neonatology. Yep. Yep. So this is a good segue from truth telling into third party obligations. Say you're a physician, say you're a healthcare worker, you have parents and a kid. How do you square your duty to do no harm to the child and to respect the parents' wishes? Yeah. And so I will see you next time for, I guess, Tarasoff versus Board of Regents. All right.